Now we are moving to the third speaker, Professor Gunter von Mickwitz from Germany. He is going to talk about neoadjuvant management in triple-negative breast cancer. Does it change the outcome?
Yeah, first I would like to thank my two preceding speakers for setting up the topic as it helps with this introduction. The reason why we are talking about neoadjuvant chemotherapy in triple-negative breast cancer is highlighted especially on this slide. As you can see here, the difference between patients with a PCR and without a PCR is actually largest for those patients that have a triple-negative phenotype, and especially the long-term prognosis. It seems that we can really select the good from the bad tumors by exposing them to such a treatment, and give a very favorable message to the patient if they have a PCR after a neoadjuvant chemotherapy with for triple-negative breast cancer. However, when we were looking at the FDA meta-analysis, the PCR seems to be a very good prognostic factor, but not a surrogate marker. As you can see here, and I have shown you these slides yesterday, actually the red line should be going from there to there to show surrogacy, but especially in the triple-negative subgroup, this seems to be not the case. And I expect, and I also mentioned this yesterday, that this is because the trials that were run at the early days were not sufficient with regard to the chemotherapy regimens that were used. And this is supported actually by this other meta-analysis that was conducted on literature-based studies, and here you can see that patients that were exposed to dose-dense or dose-intensified treatments, that here there is in fact a surrogacy seen where the achievement of a PCR or increasement of a PCR was associated with a better event-free survival. So it seems that especially for triple-negative disease, where we are much more looking into dose-dense and or dose-intensified treatments, that here this important characteristic is present. And this is also supported by a meta-analysis that we did on our data sets, where we were looking on factors between trials which were leading into higher PCR rates. And you can see here that the duration, the number of cycles actually was not very important in patients with triple-negative disease, but only in patients with hormone receptor positive disease, whereas the dose of anthracycline and the dose of taxanes was very much important in triple-negative disease, and led to considerably higher PCR rates. So taking this information for designing a new study, we came up with the design of the GEPA-6 study, where we were using a very intense dose-dense treatment, a combination of weekly paclitaxel and weekly Myoset. We used the Myoset especially, or we decided to use it especially as also HER2-positive patients were accrued in this trial and received a dual HER2 blockade in combination with the anthracycline, but also because this drug can be maybe better given in such a intensified way. And then we added in the experimental arm also a quite intense treatment with carboplatin, also on a weekly basis. We started with an AUC of 2 after half of the patients, and an interim analysis showing that this might have been somewhat too high dose. We reduced it to 1.5 after and enrolled the subsequent 300 patients with this somewhat lower dose. But still, it's a quite intensive treatment, and it was still tolerable, but of course associated with considerable side effects and some dose discontinuations. And in patients with triple-negative disease, half of these patients, 315, we also gave, in addition, bevacizumab based on the Gepa-Quinto study, for example, and also this drug, of course, which we would not give currently in this setting, added some toxicity that has to be subtracted if we are now using this schedule. You probably know the results of the study. The overall PCR rate was in favor of the carboplatin arm, and then we looked into the two breast cancer subtypes, and you can see that in HER2-positive breast cancer, no effect of carboplatin was seen, whereas in patients with triple-negative disease, the odds ratio was 1.94, so almost a duplication of the patients achieving a PCR when carboplatin was added in this dose-dense treatment. And the test of interaction here was significant, showing that this is really something substantial regarding where carboplatin works in addition to an anthracycline taxane-based treatment. And then we presented at the last San Antonio meeting 2 months ago the survival data, the first disease-free survival analysis, and you can see here that that this effect on PCR very nicely translated in a substantial improvement of disease-free survival, 76% without carboplatin and almost 86% with carboplatin, and then hazard ratio of 0.56, so that this effect was so strong that even in this small trial of 315 patients, the result was statistically significant. At the same session in San Antonio, the other trial that was running in parallel in the US by the CRGB was also presented. They gave to a sequential paclitaxel followed by a dose-dense AC regimen, carboplatin, and as it was a 2x2 pectoral design, also bevacizumab. And you can see here that also in this study, 430 patients with triple-negative disease only, carboplatin increased the pathologic complete response rate. However, when they have now presented their event-free survival analysis, you can see here that there is somewhat a trend towards a better EFS for those patients receiving carboplatin, an absolute difference of 5%, but this hazard ratio of 0.84 was not statistically significant in this not powered study for this secondary endpoint analysis. This was very nicely discussed at the meeting, and you can see here the overall the prognosis in Gepa-6 was somewhat better, but on the other hand also the overall benefit by the addition of carboplatin was almost twice as large as in the CLGB study. And Angela Di Michele tried to analyze it, where might this come from, and she came up with two main factors in here. First, the overall prognosis in Gepa-6 is probably better because we recruited in Germany, as you know, much smaller, much earlier disease patients. The number of node-negative tumors were 40 versus 60%. But what is for the final treatment effect much more important to my point of view is that we used a much more intense kind of treatment, not only for the anthracycline and taxane. You can see here the overall dose was 50% 50% more regarding the anthracycline and also regarding the taxane. All patients received bevacizumab, whereas this was a randomized question in the CLGB study. And we used a weekly carboplatin regimen, whereas our American colleague used a 3-week regimen. So with regard to what I have said at the beginning, to the sensitivity of triple-negative disease to such intensified treatments, I believe that this is maybe very much important that finally the results of GEPA-6 were so positive. Nevertheless, the confidence intervals of both trials are overlapping, so both trials can be true, and maybe the reality is somewhere in between, and we have to wait for other studies and for maybe for longer follow-up also in our trials to see where the truth is actually. What we also did in GEPA-6 was to analyze the germline BRCA status of these triple-negative cancers and looked in how far the carboplatin effect was correlated with this mutation status. And what you can see here is that in patients with a germline mutation, overall we had only 50 patients in the trial, which is roughly 20%, which is quite a large percentage, but the absolute number, of course, is low. And you can see that there's only a minor increase in the PCR rate when carboplatin was added, 11% absolute, but the odds ratio still was 1.6, but due to the small number, not a significant difference. What was very striking and, of course, surprising to us was that we saw a quite clear, intense effect of carboplatin in the non-mutation carriers. And you can see here 17% absolute difference, odds ratio of 2, and highly significant results. To me, this means that we can definitely say that carboplatin somewhat works in non-mutation carriers. If there is a lower effect or the same effect in the germline mutant patients, we can't say yet. The confidence intervals are, of course, overlapping here completely. But as I said, the effect seems to be not restricted to the mutation carriers. And this is supported very much by the survival analysis of these 4 groups of patients. And you can see here there's only one group that has a more unfavorable outcome, the blue line, and these are the wild type, the non-mutant BRCA patients receiving a treatment without carboplatin, whereas all other 3 groups are going up here, and we know from this data and other data that patients with the germline mutations have a somewhat better prognosis. It's a positive prognostic marker, germline mutation, but the carboplatin effect was mainly between the blue line and the red line, again in the non-mutant BRCA patients. Another study I would like to address here is the GEPA-SEPTO study, where we were comparing paclitaxel, solvent-based conventional paclitaxel with nab-paclitaxel. We started with the taxane and then continued with 4 cycles of EC. And we have reported PCR rates here, and the nab-paclitaxel seems to be significantly better with regard to the primary endpoint of the trial. And I'm showing this here because this effect was very much intense in the patients with triple-negative disease. And you can see here the PCR rate was 26% with solvent-based paclitaxel and went up by almost 23% to 48% when nab-paclitaxel was used. So it seems here also that especially the triple-negative patients, that the chemotherapy backbone seems to be important. And of course here we have to wait for long-term for outcome data, and it's now a good guess needed to see in how far all what I have shown to you so far is supporting that this PCR effect is also translated into a survival effect. There are further trials looking for the use of carboplatin and together with other substances, and here in the iSPY 2 trial, in one of the investigational agents was a combination of carboplatin and velaparib, and this study is a kind of search machine selecting very early potential candidates that have to be then tested in larger trial designs. And what was demonstrated in this very early study was that this patient that received veliparib and carboplatin had a much somewhat higher probability or a higher estimated PCR rate. It's only estimated, it's not real PCR rates, and the probability that this study will lead to a successful phase 3 study is as high as 90%. So it's a very a lot of statistical calculations behind that, because overall only 90 patients were recruited in this part of the iSPY 2 study. 39 received only veliparib and carboplatin, but it's a very interesting finding, and it will be very nice to see in how far this machine of selecting a new agent works. And currently the brightness study is actively recruiting. Probably recruitment will end somewhere at April or May this year, and you can see here that this is a 3-arm study where weekly paclitaxel plus carboplatin, or even then in the addition of the PARP inhibitor veliparib are given. And this trial to me is very important because it's a registration trial, a phase 3 trial, powered not only for PCR but also for event-free survival. So it's following the proposal of the FDA of a one trial registration profile, and this is exactly the data what we need. It will take, of course, some time to see if the results of Gepar-6 and CLGB 4406 are valid. So I would like to summarize the highest PCR rates and the best surrogacy of PCR and event-free survival have been seen with dose-intense treatments, which are those treatments that we are looking for in triple-negative disease. The treatment can be further intensified by adding carboplatin or by substituting solvent-based paclitaxel by nab-paclitaxel. I believe for the current clinical practice, we have some evidence to support the use of carboplatin in especially suitable patients, for example, those requiring rapid control of their local regional disease or that are at the highest risk of relapse. So I'm talking about large tumors or patients with a very young age. But in opposite what we, at least in my institution, what we did before, to use the germline BRCA status as a selection criteria, this is not supported by the findings of the Gepar-6 study. So thank you very much, and some further greetings from Frankfurt, from the new Frankfurt, the skyline, and also the very nice medieval city center. So a very nice place to live. And if you come along, don't stop over only for changing your plane. Stay a day and enjoy the nice city. Thank you very much.
Thank you very much.